So this is part 2 of our look at how hospitalization affects our pediatric patients specifically. So this kind of coincides with last week's lecture. So first thing we're going to look at are different types of healthcare delivery settings. So we know that there are lots of different ways, places that we can work in, settings that require nursing staff to be there. And we are the ones that are kind of running the show, coordinating all the services. We're creating that positive atmosphere. If we're the one in the pediatrician's office, we might be responsible for something like telephone triage. In an outpatient clinic or a satellite clinic, we might be the ones there doing the weekend and after hours care. Then we can also have home health settings where we're doing infusion, hospice care. We might be doing group therapy. So there's lots of different settings that we can work in, and depending on where we are, will dictate what our responsibilities are. As we are caring for our patients, we know that we're in different developmental stages, so we process information very differently. So we have to tailor our treatment and our approach to procedures based on that child's age and development. So for our infants, they are in that trust versus mistrust stage. So we have to give them extra time to adjust to us, to warm up to us. We want to involve their parents as much as possible so that they have that sense of security, that safety person that they have a good relationship with. We can also use something familiar, a familiar object, a security item, whether they have a blanket or a teddy bear, whatever makes them feel comfortable. We're also going to try and soothe them, distract them. We can do those comfort measures like hugs after treatments or procedures. This is where swaddling and pacifiers, music all come in to kind of help keep them nice and calm for us. For our toddlers and preschoolers, again, we still want to keep parents really involved because they are really reliant on their parents for that sense of security. We want to offer simple explanations, so very basic terms when we are explaining what we're going to do to the toddler. The more we can show them, the better off they're going to be with understanding what it is that we're telling them. We want to give them only one direction at a time, so very short, sweet directions. Make sure that they know that it's okay to tell us when they hurt. Encourage them to express any pain that they're feeling, discomfort, any fears that they have. Again, distraction is really helpful for these guys, and they are a lot more willing to cooperate if you give them the opportunity for choices. So letting them pick the color of their cast, letting them pick what juice they want after they take their medicine, letting them choose what Band-Aid. Those are all things that give them that opportunity to express that autonomy that they're looking for and give them a sense of control over the situation. And then again, hugs after treatments, getting them that comfort that they need. For our school age kids, we are doing the same things that we were doing before, but we're also going to let them examine the equipment as long as it's safe, encourage them to verbalize their fears, and then they are looking for that small reward for cooperating with us and cooperating with the treatment that we're asking. So they're going to be really happy with things like stickers, being able to have a popsicle, any type of reward for their cooperation, that encouragement that they need. Our adolescents are going to be really concerned about their privacy. We want to treat them like adults in the fact that we need to be talking to them when we are talking about procedures and treatments. So we need to explain it to them and make sure that they understand they are soon going to be advocating for their own care. So they need to be involved and understand what is going on and what we are asking of them. We can also help them work through some coping techniques, give them ideas of what to expect as far as pain management or stress, teaching them ways to mitigate that. And we know that our kids have a variety of reactions to being in the hospital. It all depends on their age, how familiar they are with being in the hospital. Did they know that they were coming in, or was this an emergent situation where we didn't have any time to prepare them? What support do they have? Do they have family members with them? Are they only relying on the staff for their support where they're surrounded by strangers? And then their overall level of emotional health will dictate how they react to being hospitalized. And we know that we do a lot of stressful things in the hospital. Anytime we separate them from their parents, we do a lot of things that are painful. And then we do a lot of invasive procedures. So all of these things are going to cause additional stress to our patients. So how do we assist the child and the parents in maintaining their normal routine? You guys can either type them in or shout them out.
Keeping a schedule?
Yep, sticking to their schedule. How do we know what their schedule is?
By communicating with the parent, talking about routines that they do at home, what the child like and does not like. Um, just asking questions, pretty
Yep.
much.
Yeah, we got to ask parents. They're going to be our best source of information. So asking them what works for their child, what doesn't. What else can we do to um, help ease that transition to the hospital setting?
You said to the hospital setting?
Yeah,
Maybe bring
Maybe bringing
things
at
from
home
home.
items.
a security item,
Yes, I was getting ready to say the same thing. Bring something from home.
something from home. Yeah. 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 Okay. So anything that we can do, we're going to have to ask parents lots of questions so that we know what is normal for that child. What do they respond really well to? Um, what doesn't work for them? Do they not like loud noises? Do they not like music? All of those are going to be essential. And then giving choices as much as humanly possible will really help to establish that normal routine. So one of the most common things that we have as a problem, especially in our younger patients when they are hospitalized, is separation anxiety. So this begins in infants as young as 6 months of age and typically peaks at about 10 months. We see it a lot in our toddlers. They're going to be very vocal about it. So there are 3 different stages of separation anxiety, and we briefly covered this last week. But the initial stage is protest. So once parents leave, they're going to have this initial outburst. They're going to be extremely upset. They're going to cry uncontrollably, call out for their parents. They're just absolutely miserable. That's that initial protest stage that we have. Then once we've kind of moved on from protest and we're getting ready to move into the next stage, we get into despair. And this is after that initial crying outburst stops. The child's going to be sad, might appear depressed. They're not going to want to play with toys. They're not going to want to engage with anybody. They're just going to keep to themselves and kind of be sad and withdrawn. Then eventually, when they come to terms with the fact that their parent is gone and they're not coming back, they will move into denial or detachment. Same phase. So they're going to deny the fact that they need their parents anymore. When their parents come back, they are going to ignore them and keep doing what they're doing. They'll go back to playing with toys, being interested in their playmates, what's going on around them. And they use this denial or detachment as a coping mechanism to reduce the emotional pain that they are feeling from their parents leaving. So this denial or detachment is a coping mechanism for them to help them deal with the fact that they're upset about their parent leaving. So the big thing for us is we have to try and move the child through these stages so we can get them back to normal. So the way that we help with separation anxiety is by encouraging parents to have a consistent goodbye schedule. So we drop you off, we give you a hug, we give you a kiss, we hand you your blanket, we walk out the door. Always doing the same steps every single time, making this short ritual. The more we can keep consistent caregivers, the better off we'll be. We'll provide another person outside of their family that they feel like they have a relationship with, that they can trust. So consistent caregivers, short goodbye rituals. And then once we get them into that despair, as they're starting to move through that despair phase, then we can start to distract them, try and get them engaged with anybody else that's around, or get them involved in an activity, something to keep their mind off the fact that their parents are gone. And then once parents come back, then we want to rebuild that relationship between them. We want to move them through that detachment phase pretty quickly. So when parents come back, you might grab the child and say, hey, tell mommy and daddy what you did today. Or did you tell mom and dad how tall your block tower was today? Something to get them to re-engage with their parents. So rebuilding that relationship when they return. Fear is another common thing that we have in the hospital. We've got lots of invasive procedures happening. We've completely disrupted the child's trust level. We've taken them out of their home. We've taken them out of their normal routine. We're asking them to do all of these things that they're not used to. So they are completely just off kilter. That fear also can threaten their self-esteem and self-control. We don't let them get out of bed anymore without help. We don't let them wear their own clothes. We only offer certain foods. So all of those things take away control from our patients. So anytime that we can allow them to have control over the situation, even if it's as simple as picking out the color of their Band-Aid, that starts to rebuild that self-esteem, that self-confidence, and give them a sense of control over the situation. We also want to incorporate those familiar rituals, routines, especially for our chronic patients that are in the hospital a lot. If there's a certain way that parents do their dressing change at home, we want to do it the same way in the hospital, assuming that there's not something wrong with the way that they do it. But using those just simple methods to return them back to their normal way of doing things. Regressions are extremely common in the hospital setting. So this is where you move backwards and you start doing things that you used to do in the past that are below your current level of development. So things like sucking their thumb, drinking from a bottle when they normally drink from a cup, refusing to use their potty chair, having accidents, demanding to be carried when they're capable of walking. All of those are examples of regressions. And they are simply a consequence of stress. So as soon as that stressful environment is removed, then that child should move back to their normal level of functioning. So we try and minimize these regressions by understanding what the child is capable of, knowing what their level of development is, and then trying to plan our care so that we're supporting that. We don't want to punish regressions. It's just the child's inability to handle that stress. This is the only way that they know how to deal with it. So anytime that they do the right thing, what we expect of them, so drinking from that sippy cup, we want to praise that behavior to motivate them to continue doing those skills that we know that they can do. So we praise appropriate behavior and we ignore regression. So here's our first critical thinking question. We have a 2-year-old. Mom says she's not going to visit because it upsets her daughter too much when she leaves. She says it's easier on everybody if she stays away until it's time to go home. How do we respond to that?
It's going to be upsetting to the child because the child is going to want their mom there.
Yeah, absolutely. That's going to do way more harm than good. We need mom at the bedside. So how do we help her work through when she does have to leave to help everybody transition? What intervention?
The goodbye rituals, the short goodbye rituals.
Mm-hmm. Yeah. Do we want mom to sneak out while the child's asleep?
No, because when she wake up, she's going to be crying.
Yep. Yeah, no, we want mom to explain the fact that she's leaving, tell her when she's coming back, assure her that she's coming back, having that short goodbye ritual so that we're avoiding that protest and breaking that trusting relationship. So we know that she's going to go through protest. We can reassure her that she's going to be okay. It's just that initial outburst that she's working through when mom leaves. We can distract her so that she gets involved and we can minimize that outburst. And then reestablishing that relationship when she comes back. But we definitely have to have mom there at the bedside so that this little girl does not feel abandoned. So talking about pain, according to the American Academy of Pediatrics, pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. So we take our patients at their word, understanding that they are the only ones that know what it is that they're feeling. So even our youngest patients can express pain, whether they're verbal or not. So we assess this using an appropriate pain scale and record it routinely with our vital signs and as we're giving medications. And the reason this is so important is when we have pain, we secrete higher levels of cortisol, and that can help cause issues with our immune system. So help having us not have as good of an immune response. So we may experience more infections, and we also show delayed wound healing. So keeping our pain under control is extremely important. We have to use the right pain scale according to the child's age and development. And also remember that our toddlers might also be feeling anxiety in addition to the pain that they are feeling. So we have to take that into consideration as well. So for our nonverbal patients or our infants that are too young to be able to tell us when they have pain, we're going to use an observational scale. So either a NIPS scale, which is our neonatal infant scale, we can use a cry scale, the FLAC scale. All of these look at specific observations and use those all together to give us a pain scale. So like our FLAC scale looks at our facial expression, the position of our legs, our activity, our crying, and whether or not we're able to be consoled. Our cry scale is going to look at crying, whether or not we need oxygen, our vital signs, our expression, and our sleepiness. So observational things, we don't need the patient to tell us anything. We can just look with our own eyes and do our assessment and determine their level of pain from there. So for our 3 to 8-year-olds, they're starting to understand faces and beginning to understand numbers. So we're going to rely on our faces scale. So for the faces scale, we have these cartoons that show our level of pain as written on our face, and we ask the child to pick the face that matches their level of pain. We can also use a poker chip scale for our kids that are 3 to 8. And this is where we're going to give them 4 items. So poker chips, whatever. Give them 4 of something and then ask them to give us back how many correlate to their pain. So if we give them 4 and they give us 1, it means they're only in a little bit of pain. But if we give them 4 and they give us all 4 back, then they're in the worst pain of their life. So we can use that. For our older patients, 9 and up, we can use the number scale. And typically the number scale follows along with the faces scale so that you get an idea of how big is 10, how little is 0, what are the in between. So anybody 9 and older can use a number scale. We also have an Oucher scale. So this is used anywhere from 3 to 12. And this scale is just like our faces scale, but it has culturally specific photos instead of those cartoons. So we know some cultures are extremely expressive when they experience pain, and others have a very flat affect. You really have a hard time reading their facial expressions. So these pictures will help the child to relate a little bit better to how they may experience pain and how they may express pain by having those culturally specific photos rather than just that cartoon drawing. As we're managing pain, we want to start with our non-pharmacologic techniques. So anything other than medication. We can use drawing, distraction, imagery, relaxation techniques, especially with our toddlers and preschoolers. They a lot of times don't know the words to express what they're feeling, but they might be able to draw a picture about it. So giving them that opportunity to draw a picture or color something that helps express what's going on with them, how they're feeling, any fears that they might have. It's a good way to get inside their head. Also, cognitive techniques, things like thought stopping, where you repeat stop over and over and over until that negative thought goes away. We can also use massage. It's very effective in alleviating pain and helping provide that positive feeling to minimize that negative response that you feel. And when we get to medications, we have to understand the route of elimination. So most of our medications are going to be metabolized in our liver and then excreted by our kidneys. So depending on the child's age and how mature their organs are, will dictate how they process medication. So if we're really young and our organs are not developed, we're going to be at higher risk for reaching toxic levels because we haven't processed those medications effectively. If we're older and we have mature organs, then we can expect a closer to adult response to a medication. So we use weights to help keep us in safe ranges for our medications, give us a baseline general idea of how we expect it to work. And then based on what we're seeing, in the patient's condition, that will help us to tailor those doses to make them even closer to what we need. The whole purpose of providing medication for pain relief is so that our patients can focus on their activities of daily living, their surroundings. They can have a normal life as much as humanly possible and not be fixated on their pain. If we don't treat their pain, then that's going to be the only thing that they can focus on. And we're going to have to give higher doses of medication to stop that pain, the more that they focus on it. So we find that with pediatric patients, if we use a preventative pain plan, we have a better response. So if we give them lower doses of medication on a routine schedule, then we can keep them at a nice level where they can function and not be focused on their pain and have that nice relief, rather than waiting until they're in excruciating pain and giving them a one-time dose of something and then it coming right back. So having to use more medication on that PRN schedule versus giving them that consistent relief. So preventative pain plans, those low dose medications around the clock is going to be the most effective way to control a pediatric patient's pain. Common medications that we use, acetaminophen or Tylenol is going to be our drug of choice for mild to moderate pain. We can use NSAIDs like ibuprofen as well. We do not give aspirin to patients with flu-like symptoms because it can cause Rye syndrome in our pediatric patients. And we will talk about that later. But remember, anytime you have flu-like symptoms, we do not give aspirin. So that's why we rely on acetaminophen and ibuprofen. So those are going to be your mild to moderate pain medications. We can give opioids for severe pain, so surgical pain or a trauma. If we have a chest tube or something that's going to be extremely uncomfortable, we can use opioids for that. And remember that in the event that we have an opioid overdose, we're going to give naloxone as our reversal agent. If we're doing just a short surgical procedure or a dental procedure, something like that, we can give fentanyl, and that's going to give them really good pain control, help them to not remember what we did to them, and it has a very short duration. So it's going to work very quickly and effectively and not last for a very long time. So it's great for those short surgical procedures, dental procedures, things like lumbar punctures. Fentanyl is going to be a great medication for those. And then we also have topical anesthetics that we can use. So our EMLA cream that we put on before we do an IV, or if we're having to suture the skin. Just remember that these topical anesthetics only go through a couple layers of skin. So if you're doing more than a couple layers, then we want to use something else in conjunction with it. So that's just going to be a local anesthetic, numbs the top of the skin so that you can do this procedure without it causing pain. So we can use EMLA cream all the way down to our NICU population. Our youngest infants can have EMLA so that they can not have pain associated with things like IVs typically. Conscious sedation is something that we do when we have to do a procedure outside of the operating room. So this is where we're giving IV medications so that we impair consciousness, which means they're not going to remember, but they're still able to retain their protective reflexes. They can maintain their airway. They can respond to commands, can still move their body around. So help them forget, but still have control over their body. These patients will be a 1-to-1 nurse-patient ratio until they go back to where they were before the procedure. So their vitals have to be stable. They can talk to us appropriately. They can keep down fluids. They have that pre-sedation level of responsiveness. So moving on to some other things that we have to consider in the hospital. We need to use the professional language interpreters when we have patients that English is not their first language. So by using a professional interpreter, we improve the communication between the parents and the healthcare team. We don't use family members because of the fact that we're using medical terminology. We don't want information to be lost in translation. Hospital sites are required by law to provide these language interpreters at no cost to the family. So we want to make sure that we are using them to their fullest potential. We also can cause a lot of undue stress on that family member that is required to translate. So we definitely don't want to do that. We don't want to burden the family anymore than we have to. So use those language lines as much as humanly possible. We also need to be aware of cultural norms. So we need to understand how to approach different cultures and how our nonverbal behavior also affects the message that we're trying to send. So we want to make sure that we're exercising that cultural sensitivity so that we can make them feel comfortable, decrease their anxiety, assure them that we're there to build that nice, trusting relationship. And be honest about what you do and don't know. Nobody's going to be offended if you ask questions when you're unsure of what the appropriate intervention is going to be. So some of the things that we have to watch out for: personal space. Everybody has their own bubble where they feel comfortable. And some people don't like you to be very close to them. It makes them extremely uncomfortable. Other people, if you would stand across the room from them, you would feel as though you were very cold and off-putting. You didn't want to be there. So being very aware of personal space. Also smiling, even though we may intend it to be friendly, don't intend anything malicious. Some cultures might feel that smiling in a serious situation is inappropriate, or that you don't feel like their situation is serious, or that if something sad is going on, that you're not taking that into consideration. So keeping that professional demeanor, being aware of how you're being perceived. Same thing with eye contact. Sometimes direct eye contact is encouraged, other times it's seen as disrespectful. Anytime we want to touch a patient, we need to ask permission first. We need to make sure that we are not giving misleading messages. If we pat a patient on the head, it may imply that we think we're superior to them. Same thing, other cultures may see touching of the head as trying to rob them of their soul. So make sure that you ask permission before you touch. Explain the touch that you're going to do so that they can say yes or no. I mean, every patient has the right to say no to touch. Also, focus is something that we have to be aware of. Some families will be very future focused. What are the long-term impacts of the situation? Others will be only focused on the immediate here and now. So understanding where that focus is so that you can tailor your interventions to what's going to be appropriate for them. The majority of this is going to be using your critical thinking skills, reading the room, kind of watching how other people interact together, and then asking questions when you're not sure. So culturally sensitive care, which of these is going to be the appropriate intervention? Yep, we're going to use our medical interpreters, not use family. What about these two?
Well, we say making eye contact, but you have some cultures that don't like to make eye contact. So we'll practice the other one, right?
Yep, following cultural practice. So we know that eye contact is not the same in all cultures. What do we think here? Yep, respect personal boundaries. Everybody has their own level of comfort with how close you can be. You guys got it. Always ask before touching. And last one. Yep, keep our professional expression. Smiling can be misinterpreted. Not only do we have to worry about our patient's reaction to being hospitalized, but they also come with parents and other family members, and they have their own reactions to their child being hospitalized. So we might see a lot of anger, crying, aggressive body language as parents are venting their feeling. We have to remember that not only do we have the child and their response, but the parents have their own history, their own number of experiences with hospitalization. So they may be projecting their past experience onto their child's experience. So even though everything could be going right with their child's hospitalization, they could have had a bad experience in the past that is kind of causing them to have some negative feelings about the current situation. So we have to be understanding and accepting of everybody and all the problems that come with them to be successful in the pediatric setting. And the biggest thing that breaks down and causes issues with hospitalizations is poor communication. So if we don't communicate effectively, then we cause an unnecessary level of fear. So the clearer we can be in our communication, we can avoid that unnecessary fear. So making sure that if we have a hostile parent and we need to de-escalate the situation, that we're using those I statements. We're restating what the parents are telling us that they're feeling. I hear you say that you're feeling angry because of X, Y, and Z. You want to acknowledge their feelings, help them to understand that we do accept their feelings. We understand that's what they're going through. We want to be honest and ask questions on how to improve the situation, and then work together to make a plan so that we can move forward. We can also role model appropriate behavior so that we can help them to get into that behavior that we are expecting of them. If you get into a tense situation with a family and everybody is yelling, you'll notice if you bring your voice level down, everybody in the room is going to come down with you. So if you've got somebody yelling in your face, if you whisper to them, they have to stop yelling to hear you whisper. So they're going to be more likely to come back with their response being a more normal volume because they need to be able to hear. So little techniques like that are really helpful for de-escalating situation. We need to be able to meet those emotional needs of everybody involved, the parents, the child, any outside family members that might be involved. When we're explaining things to our patients, we want to be as matter of fact as possible. We need those simple explanations. We need to show them exactly where our surgery is going to happen, give them an opportunity to play with things that they might see. Also give them a realistic timeline. So we're going to have to relate whatever time we're trying to tell them to something that they know. So the procedure will take the same amount of time as your favorite TV show. Mommy will be back after lunchtime, or after you lay down for your nap, we're going to do this. So you have to relate time to something that they know. If we tell them 20 minutes or 2 o'clock, that means absolutely nothing to them. So making sure that we are taking that into consideration when we're explaining things. And we don't want to provide too much detail because that's going to increase our anxiety level. So just simple facts. We know that hospitalization can be frustrating. If they're separated from their parents for an extended time, they might be missing out on some of that affection that they would receive. We're disrupting their normal schedule, their normal environment. So we want to foster attachment as much as humanly possible and keep those developmental activities on track. This is why we allow for really liberal visiting hours in the hospital. We want parents to be at the bedside as much as possible because they know their child the best and they give them that sense of security that we can't provide. Consistency in caregivers is going to be the best way to assist parents in maintaining that security. We can do sensory motor activities to help with development, like rocking, talking, cuddling, bathing, using mobile, singing. For our older kids, keeping them involved in coloring and playing to their developmental level and their medical condition. So why is it that we want consistent caregivers?
Would it be provided security and trusted?
That's one of them.
And also it increases the understanding of the normal routine. A consistent caregiver know what the child does from morning until throughout the day.
Yep. When you take care of them all the time, you start to know what's normal for them. Whereas if you've got a different nurse taking care of the patient every single day, you've got to re-explain every single day what your normal routine is. You have to answer the same questions because you just don't know. So consistent caregivers alleviates a lot of that extra stress and tension. It's really nice having that familiar face. So some things that we can do to improve care and the overall hospital experience. We want to encourage early discharge, even if that means that we have to continue with home care once we're home. So as soon as they are in a safe spot where we can send them home with some supplemental resources, we want to get them discharged home. Their home environment is the best place for them to be, back to that sense of normal. We want to provide a happy, relaxed environment, do everything that we can to mitigate some of that stress. We have to be flexible. If you are not flexible with pediatric patients, you are not going to be successful. They will never do anything on the timetable that you expect or the way that you expect them to do it. They're always going to throw you a curveball. If we don't have private rooms and we have to use a roommate, we need to make sure that they're age appropriate. So you're not going to pair an infant with an adolescent. The infant's going to cry and drive that adolescent crazy. Also doesn't do anything for either one trying to meet those developmental milestones. So pairing two adolescents together where they can have that socialization and that peer influence is going to be a lot better than pairing them with a younger child that's going to be obnoxious to them. We want parents to be at the bedside 24/7. We understand that that can't happen, but we want all the time because of various circumstances, but we want to encourage it as much as possible. And then providing those developmentally appropriate activities. So giving them toys that are appropriate to their development, encouraging them to do activities in the hospital, social groups, anything that we can to promote development. In our adolescence, they are starting to understand the implications of their disease. So what are the long-term consequences? And we know they have an advanced level of thinking. So they are able to problem solve, start thinking about how this is going to affect them as an adult. We need to make sure that we are including them in their plan of care so that once they leave the household, they are able to make these decisions and manage their own health. It also helps them to gain confidence when they have their parents to still help guide them through the process. We're gonna keep going here. We talked about roommate selection, making sure we're pairing age-appropriate patients together. Adolescents are gonna do better when they're paired with other adolescents so that they can have that socialization. And we want to make sure that we are paying attention to where we're locating these patients' rooms. We're gonna want our adolescents can be further away from the nurse's station. They can have some independence. Our infants, we're gonna be able to keep an eye on them all the time. So we're gonna put them closer to the nurse's station. So thinking about location as well as who we pair together. And then we have to talk about confidentiality and legality. So this is where HIPAA comes in. We can't discuss information with anyone other than the patient. And we have to watch out for emancipated minors. So these are people that are under the age of 18, but they are no longer under their parents' authority. So these people will have documentation saying, I am emancipated. My parents no longer have any control over me. If someone under the age of 18 is married or in the military, they're going to be automatically considered emancipated. So they don't have paperwork to go with it. So anybody that's emancipated is able to give their own consent for medical treatment, even though they're not 18. Also means that we cannot release any information about them unless they tell us that we can. So even if their parents ask us questions about them, we are not able to release that information unless that patient says it's okay. Each state is a little bit different when it comes to adolescent patients, when they can give consent, what information can be released. So make sure that you are familiar with your particular state's laws when it comes to adolescent patients specifically. Discharge planning. So we need to start this as soon as they are admitted to the hospital. We need to make sure that we are giving parents little chunks of information all along the way, so we're not bombarding them with all this information right before they go home, and then they'll retain absolutely nothing. So teaching them all along the way. Anything that we expect them to do at home needs to be written down so that when they forget, they have something to reference. We also need to make sure if we're doing any procedures at home, so giving an injection or doing a breathing treatment, that we have physically watched the parents do it successfully while they're in the hospital and we feel comfortable with their abilities. There are a lot of behavioral problems that can happen as a result of being hospitalized. So we might see some of those regressions that we talked about. We might see aggressive behavior that comes out as a response of being hospitalized. So we've got to help parents work through these. So anticipate these behaviors happening. As soon as we get home, we want to integrate that child back into the family as much as possible. We want to take the focus off of our illness, go back to praising those normal everyday things. We still need to be firm and consistent when we have misbehaviors, but still being kind, being truthful so that we can rebuild that trusting relationship, allowing them free play, listening, answering any questions they have, and prevent those long periods of separation until they can regain that sense of security. The last thing about discharge is our discharge charting. So this is our chance to wrap up everything in a nice, neat little bow. So we need to document who took the patient home, how we identified them, when they went home, what their condition was. So like a nice little snapshot of how they looked when they went home, how they left, what their vitals were, all of our discharge instructions that we gave. So create that nice snapshot of what your patient looked like when they left so that you have something that clears you of anything should there be legal issues that come back later. So that nice little bow on the end of your hospitalization. We talked about discharging home with home care. So sometimes if patients have either chronic conditions or they had an acute event, but they're stable enough to go home, we will send them home with home health care. So where community agencies come in and provide some of those additional resources. So infusions, hospice care, palliative care, we might do therapies outside of home. All of those are opportunities to get them back into that home setting and get them out of the hospital quicker. We can also do respite care for our primary caregivers when child has a chronic condition. So this gives them an opportunity to shop, take care of themselves, do any business that they need to without having to worry about their child being taken care of. Gives them an opportunity to just step away for a minute. We also have to keep our school systems integrated into the care of a patient. So we need them to understand any new treatments, medications the child might be on, therapies they might need during the school day. We also have to make sure that our patient has their school assignments while they're in school, is able to stay on top of things and stay connected. And let's go ahead and do this one. So we have a 16-year-old high school junior varsity athlete that has a car accident. She has head and facial lacerations and a fractured femur. During our nursing assessment, she avoids eye contact and is withdrawn. She also says that her junior year has been ruined and she can't possibly go to prom looking like this. What developmental concerns are influencing her recovery, and how do we include her in our care plan? What do you guys think?
As far as developmental concerns, I would think she may become isolated. She's a girl. Girls are very particular about their features, their looks, and she's headed to prom. So I would definitely think she may become isolated. And as far as her recovery process, I think we should include her in setting short-term goals. So therefore, she can work towards recovery. Once she accomplishes a goal, it'll help her with confidence building and push her to keep going. So at this point in age, it's like you're finding yourself. So definitely like just allowing her to set her goals.
Mm-hmm. Yep. So you mentioned the fact that she's 16. She's all into her appearance and she's getting ready to go to prom. And she's got facial lacerations from this car accident. So we might have to teach her how to cover those up, how to use makeup to cover those up so that she can feel secure in her appearance. Also helping her find a dress that covers her cast. Something simple like that. Who do we want to come visit her in the hospital?
Her friends.
Yeah, friends, teammates, helping her work through the recovery process, being able to play sports again. Her peers are going to be really influential on her overall just mental well-being. Also, coaches are great to come in and visit so that they can provide that extra support, encouragement to help her get back to normal after injury. Okay, guys. That is going to be it for our PowerPoint today. I am going to skip our Kahoot so that we can still get out on time. You guys had your first set of NCLEX questions that were due last week. If you had trouble setting those up and haven't turned them in yet, reach out to me and I can help you set them up. You can still turn them in for partial credit. This week, we only had our discussion question that is due. For next week, we have our second set of NCLEX questions that are due, and we will have our third quiz, which will go over the information that we covered in class today. Just like we did for week 3, you will have a screenshot to help you set up your NCLEX questions for week 4. Or I'm sorry, for week 5.